Hi, my name is Dan Gomez, and this is Mental Health Supra Omnia. That's mental health above all. We are all about understanding and identifying mental health issues and finding a path to help. Up to 9% of the US population, that's 30 million people, will have an eating disorder in their lifetime, with the incidence rate twice for women as men, and children are not immune to eating disorders as well. So I want to explore eating disorders in greater detail, and we have with us today two guests. The first is Tamie Gangloff. Now, Tamie is a marriage and family therapist. She's an author, adjunct professor at Westchester University. Her clinical expertise focuses on the treatment of eating disorders, substance use, and chronic illness. She's president of the Southwest Philadelphia chapter of IAEDP, which is the International Association of Eating Disorder Professionals. And she's a group leader at the National Alliance for Eating Disorders. She also has a new book coming out, Chronic Illness and Eating Disorders. I have read that book from cover to cover, and we'll talk about it in a minute. Fascinating and great book. A second guest is Catherine Lodwick Jones. Now, Catherine is a licensed professional counselor and board-certified dance and movement therapist, specializing in the treatment and intersection of eating disorders, neurodivergence, and LGBTQIA-related concerns. Catherine is the lead of Equilibria's Eating Disorders Center of Excellence. Now, there are many facets to eating disorders, and Tamie, your book focused on a lot of them. But for today, let's focus in on what I think are three key issues. Number one, triggering events. Two, coping skills. And three, how to get help. So first, Tamie, could you tell us a little bit about your lived experience relative to those three concerns?
Yes, my personal history, lived experience that you read, all 75,000 words in PDF. That's amazing. I always feel a little bad when people have to read it that way, but thank you so much for reading. My lived experience, starts when I was a kid. I grew up with scoliosis, and so you also don't graduate from scoliosis. I still have it, even though I have metal in my spine. And so my scoliosis, along with family concerns, a family kind of diet culture, and some, bullying, sexual trauma at that time really created that perfect storm to create an eating disorder that I struggled with for many years. It also created the perfect storm to develop alcoholism, which I have been sober for 28 years now. So I'm grateful to have been able to get sober and fully recover from the eating disorder as well. I had a complex spine fusion almost 7 years ago now. And so that kind of led me to refocus on the chronic illness piece and how it impacts so many of us. And then also the intersection between eating disorders and chronic illness, which is what led me to write a book. And my, kind of ongoing journey with chronic illness and eating disorders. Chronic illness minus my eating disorder. And I currently, let's see, I lost my train of thought and refocus me.
Well, that's okay. Catherine, I know that you were eager to jump in and ask our first question.
Oh my gosh, ask me anything. I'm much better with answering questions. Ask me anything.
Yeah, something. And this has always been really interesting to me is you talked about your scoliosis and chronic illness as being a part of who you are, but not your entirety. And I think that's incredibly common for a lot of folks, whether they have a chronic illness, a long-term injury, and especially eating disorders. And I would imagine that your lived experience also helps you connect with clients who have a similar experience. Can you tell me a little bit more about how that kind of enriches the therapeutic relationship?
Yeah, I think that's a great question. I think for anyone with certain lived experience, it helps enrich that, right? I would say, you don't have to have lived experience with an eating disorder to be a great eating disorder clinician, although the relationship is different. And so I actually talked to two different friends the other night that are struggling with their chronic illnesses. One was she's had a number of chronic illnesses and then had a really awful car accident. And then the other just was a runner and diagnosed with a really kind of rare neurological disorder. And so having that conversation, they even both said, nobody really gets this, right? Getting it from a personal level, like what it's like to, and then I shared on social media, like sometimes you just need somebody to say this really sucks and I get it, instead of the toxic positivity. And so I think it's helpful for people to understand that. I know even today, right? Today in this moment, not feeling great, like just to know that I know what it's like to be in a body that's either has a lot of limitations, has chronic pain, that limits your overall life, and then also how to continue to live. And the goal is to thrive, not just survive, right? I know we always say that, but to, like, how do I do that? And some days we're just surviving. And so I think having that shared experience also allows others to open up more, because it's something that we as a society don't really talk about, right? It's maybe like the big major illnesses people might talk about, but for that day-to-day pain and struggle and things, people tend to isolate. And so to connect with somebody that's like, okay, yeah, I get where you're coming from, is really, really helpful. And I think creates a safe space to do that, knowing that I get it. And I'm not going to just tell you to like, but your other parts of your life are great. I explained to somebody last week that, even though most parts of my life are really great right now, it still kind of casts this shadow over the rest of your life sometimes. And so for people to understand that, even though all these things are great, having this chronic illness, pain, whatever it is, can cast this shadow, and it's hard to see outside of it sometimes.
So Tammy, go back to the beginning, because I, with myself or with various family members, children, whatnot, I've had to go on quite a number of doctor appointments, and you want them to be as clear as possible, and I get that. In your particular case, you described the back brace that you got as I guess it was as a teenager, as demoralizing, and that you had a deformity. Is there anything that should have been said to you to try and be more compassionate, or to still be direct, but maybe not hit you with the 2x4? I mean, when I read that, it was like, I just got taken aback. I had to stop for a minute and think, how would that feel if someone told me that I had a deformity, and I had, or I felt like I had a deformity and had to wear a back brace the rest of my life. Is there something that could have been done differently?
I'll start by saying I've met a lot of those PTs and orthotists at the scoliosis conference last year, and a lot of them have shifted that language, which is really helpful. I can't speak for all doctors that they've done that, but I think just the different language, right? Because when you look up the word deformity, as I said in the book, when you look up the word deformity, if you just put that in and look up synonyms, it says ugly, gross, disgusting. And then you're like, oh, I guess I am ugly and gross and disgusting. I already feel that way. And I think maybe just more of an explanation as to, I think when kids are diagnosed with something, they're talked at instead of, talked to on their level, and really explain what's going on. So it's kind of like, you have this thing, you have a deformity, here's this back brace, wear it until we tell you not to. And if you don't, we're going to put you in a body cast, is what was told to me. And so I was like, okay, I have to do this thing. But, and so I think just really just explaining, like you're on an equal level. I talk about, as an adult, we want a therapeutic alliance with our medical team, but kids need that too. Kids, teenagers need that too. And to really be more gentle with our words. Yes, the medical diagnosis does include the word deformity, but how about explaining, your spine has a curve, it's curved more than we had hoped. This is one treatment option that we think will be really helpful. So I think just kind of that gentle explanation, using words that aren't so harsh, such as deformity, because that really sticks with somebody. I mean, it really stuck with me, as you read my words. It really stuck with me for many, many years. And so, and I would think that a lot of people that have heard similar words, whether it was for scoliosis or another type of deformity, that stuck with him as well. So really just partnering with a patient at any age and talking to them like you would a family member. Actually, I had said that to one of my doctors a couple months ago when I didn't like his responses to things. I will always say, challenge your providers always, because they are there to take care of you. And I said, what would you tell your family member to do? And he paused. I still didn't like his answer, but and so for medical providers of any kind to, talk to kids like they would talk to their own kids if they have them,
Right.
with that kind language and really explaining like this is, and that compassion, like I know this is really uncomfortable and therapy. Not that it wasn't a thing back then, but it wasn't really as common as it is now for somebody to go to therapy. And so I think therapy would be really important to have at that time. There are some support groups for teenagers and kids with back braces, but really just explaining like, I know this is really uncomfortable. Like the process of getting the back brace is really uncomfortable. I'm sorry we have to go through this. I'm here with you in it. Just really that safe, secure place that I didn't have,
Right.
so.
Right.
I think
Let me
that's
get
what
one
struck
more.
me.
Go
Oh,
ahead.
go ahead, Dan.
Oh, no, please go ahead.
I think that's what struck me is that it was not that long ago. I acknowledge that recommending therapy is much more commonplace now, but even if it wasn't as common to go to therapy as an adolescent or for an injury or a chronic illness, it felt like a complete disregard to the psychosocial impact of what was happening to your body during a really vulnerable time. And we know no matter what is happening to you, that middle school, high school age, that 11 to 14 is so impactful. There's so many body changes, there's so many social changes, there's so many neurological changes. And to be both physically disabled, but then told these really unhelpful, unproductive things by someone who's supposed to care for you and give you hope for the future has a really negative impact in the long term.
Absolutely. And yeah, that's a really good point. Like I also wore like braces on my teeth and that's the one of the smart kids. And like, I think it's all of the normal middle school things were also happening. Which again, I think nobody gets through that age unscathed by something. So you add that plus this and it makes it a lot harder.
I want to go back again to one other thing that struck me. I read it in the book. You mentioned it, but sexual assault and trauma is strongly associated as a strongly associated risk factors, or are strongly associated risk factors for eating disorders. But many times, according to the CDC, the trauma is not disclosed till years later, if ever. So, if that's the case, then from a personal or even from a clinical perspective, is there a way to help those trauma victims? Is there anything that we could do or see or know? Anything that should be done? Any way of reaching out?
I guess in the way of reaching out, I think when we talked yesterday, that kind of creating that safe space, whether it's a family member, a friend, or a clinician, hopefully they end up in a clinician's office, right? To create that safe space so that they feel comfortable enough to share it. And building that trust might take a long time, but just being that really safe place. And that's our work as far as a clinician to be able to create that safety for our clients and also work on creating safety and containment. And as a clinician, I think we usually have a good sense of where some of the relational trauma and other things might be coming from. It just is, let's continue to work towards that safety and containment and grounding so that they might feel comfortable. Because when we start to see chronic relationship challenges, as we get further into adulthood, a lot of times there's a connection to sexual trauma or other types of relational trauma.
Okay.
Mhm.
Thank you.
Okay. So a bit later in life, you were confronted about your weight loss by your doctor. Is that
Yes.
something that was monitored throughout your life, or was that all of a sudden this guy looked at you and said, "You've lost weight," and confronted you on it? Should that have been
Yeah.
evaluated more frequently? I mean, what was happening there?
Should that have been evaluated? Yes. Um, Again, I think eating disorders were not on the radar kind of back then. I mean, when I went to treatment the first time, I was, I think, 19. And it was at, really the very first treatment center in the country for them. So I don't think it was monitored. I think it was something that was dismissed in adolescence as, you're tall, you're growing, you're fine, you're just built that way. But when it was my spine surgeon, and I actually saw him as a follow-up for like a second opinion a couple months ago, and I reminded him of what happened because it was so impactful. And I don't know that he quite knew what he was doing at the time as far as how much impact it would have had on me. Um, but having any surgery, right, our bodies need a ton of nutrition to recover. Even now that I'm in this recovery phase from this injury, you don't have an appetite sometimes because you're in pain. So like I still am very diligent about making sure I get what my body needs, but when you're in an eating disorder, you're just like, cool, I can lose weight now. And so I think that's really what happened back then, right? This is a good time to diet. No, it's not. Your body needs so much more to recover. And so when I went in to see him, I think if it was a friend or a family member that said, they were worried about my weight, I might have gotten angry with them. Uh, you're giving me a hard time. Like I've just been through this surgery. Now you're making comments about my weight. And so for him to say that in a really clinical way, like his mind was like, I'm worried that you are 25 or 6 and you might have osteoporosis, which is common in somebody with an eating disorder. And so for him, it was, you have lost weight. I can see that you've lost weight, even though I was like, no, I haven't. He's like, yes, you have. And this is how your bones lose calcium and you need to get a DEXA scan. And so it was nice that it wasn't, it was done in a compassionate way, but also very straightforward. There was no emotion attached to it on his end. He just was stating a fact. The fact is you've lost weight, you've had a spine surgery, you're not where your weight needs to be, and we need to do something about it. And so I think that non-judgmental approach was really helpful. It shook me. It shook me enough for me to say, like, okay, maybe I do need to do something again. I don't want to keep living my life this way. So Dr. Rushton, he's at Lankenau. I can say his name. His name is in my book, but so I thanked him for saying that and gave him one of the little cards that I made for my book and said, just so you know, you impacted my life back then in a huge way. And he probably had no idea. Um,
That's
so
great.
yeah, I think doctors have the ability to do that. There's very little education in medical schools for doctors on eating disorders. And, we, I say we of the eating disorder field, I can't speak for all of us, but in general, know that there's very little education for doctors. And so any chance that I get, or that we get to get in front of a group of doctors or medical students to educate, the better, because a lot of times that might be the first person that's going to say something that could really change somebody's path as far as getting into recovery or not.
Hmm.
I think that's so true. And I wanted to, you segued right into a thought that I had, which was how can folks, even without an eating disorder history, benefit inadvertently from a provider, whether it is a therapy clinician or a medical provider who has more advanced training or even just more awareness about the language that they use surrounding weight and body image.
How can the clients benefit from that?
Yeah.
Question. Yeah, I mean, I think it's we're all none of us are immune to comments about weight and body, no age, gender, anything else. And so for a doctor to have an awareness of just how they have those conversations around weight and body is really, really important. I have these cards that we make them at work, but some of the nonprofits make them like, please don't weigh me unless it's medically necessary. And so for doctors to understand, that somebody has the right to refuse getting on the scale because it might be really upsetting. And so just to have that awareness, and that somebody might be really sensitive about their body's appearance or shape or size or scars or something else, just to know that, this person is a person and not just a set of symptoms. And so to have gentle conversations about weight and body the same way that we should have the conversations about a back brace with a teenager, right? We should have those conversations about weight as well.
I think that really highlights just how approachable and impactful a general awareness can go, right? We don't have to have every medical provider have a whole course on the treatment and assessment of eating disorders, but rather the acknowledgement that talking about it in a compassionate way, that collaborating and allowing your patient or client to have agency in the kind of patient provider relationship is so impactful. It builds that trust and it likely allows that patient or client to feel more comfortable addressing issues that might come up for them they're not comfortable addressing elsewhere.
Absolutely. And that having that trust is so important. And really the conversation of weight should only come up if it's really something that's going to impact somebody medically. And there's this assumption that, and I told this to a group I saw the other day. When I got back from, and I won't do this again, last May, I went to 3 conferences in 3 weeks. I went from Boston and then DC and then Boston, and then I got bronchitis because my body was like, you're done. And so I went to urgent care and they had me get on the scale. And so whatever, I had like my coffee and my phone in my hand and all the things. Like I was in my mind, I'm like, this is a joke. Like you're weighing me because I'm here because I have a fever and whatever. And so when the doctor came in, I said, and I don't know what my attitude was like. It probably was a little bit of my Jersey attitude, but said, if I had been, 50 pounds heavier, would you have said, here is your Z pack and you need to lose 50 pounds? And I think he got what I said, but I kind of was just saying like, this is really ridiculous that it's not medically necessary for you to check my weight. You're giving me the same antibiotic, whether I am my weight or a little higher, a little lower. So, just to have that understanding and know that there are definitely some medical conditions that there are weight concerns, and there are a lot that there are not. And so to have that conversation with your medical provider, I saw a new doctor for something this week, last week, I don't even know. And I got on the scale just because it was my first time seeing them. But when I go back, I don't need to because why I'm going to this doctor has nothing to do with my weight. And so for doctors to have that conversation. And then when they do have weight concerns that are valid, that are related to their condition, to do that in a really kind, compassionate way. Because so many people already feel self-conscious about their size. And so we don't want to also, it happens the other side too. If somebody's needs to restore weight and is a low weight, they also can feel that way and feel judged. It's not just somebody who might be told they need to lose weight. There's definitely that weight stigma that we can talk about too, but and so for a doctor to have that really gentle conversation, I have had the conversation with doctors and with physical therapists about spine conditions and weight, and there's some validity to it, and I don't need to get on the scale when they see me.
Catherine, I know in speaking to you about eating disorders, you've mentioned in a number of clients that you've seen initially presented with or came to you for other issues, but then a month or 2 months into it, then disclosed that they had an eating disorder. And Tamie, you probably have seen that as well in your therapy. Is there is there a way of, is that just a natural process, or is there a way of allowing people to disclose everything that they need to get out so that they can get help? Obviously they've come to you guys, for you ladies, for help, so it kind of seems like the slow reveal may not be the best way, but I guess it's most comfortable for them. But how do you help? How do you make sure that you're giving them the best care if you don't know everything at this point, in the first session or two?
Do you want to go first, Catherine?
Sure. Yeah. Yeah. I think it's really case by case. Some of my clients don't realize that they have a history of an eating disorder because oftentimes, as we see, the disorder is rooted in family culture and family norms, right? Whether your parent really enforced diet culture in a really problematic way at a young age, or created a food hierarchy where these are the healthy foods and these are the unhealthy foods, and we don't have certain foods in our home. And then you don't realize as a young adult the way in which you're engaging with food is disordered. And then when life happens, right, you go to college, you have a breakup, you start coping in other maladaptive ways. It is this perfect storm of maybe not even quite realizing how impactful that was and not having the verbiage or the understanding for how to get help. And gratefully, they were able to seek help for other things that manifested because of their original eating disorder, but not realizing that's what the root cause was. And then I certainly think there are other clients who, whether they're having a hard time because of denial or shame or stigma, they realize that they have an eating disorder, and it's easier and safer to talk about the peripheral things when you're building that early therapeutic relationship. And until you feel safe enough, until you feel like I'm ready to confront this and get support, all of the other things feel a lot louder and easier to manage. What about you, Tamie?
I'm like nodding, yes to all those things. Yeah, I think that I second all that. I think that when somebody comes into treatment, they might already know, like, I have an eating disorder, but maybe they've never talked to anyone about it. They're ashamed to talk about it, and so just building that trusting relationship is going to be really critical for them to. So you might know as soon as they walk in and after they say a few things that they have an eating disorder, but giving them the time and space to feel comfortable and disclose. And then if they haven't, like, approaching it gently, asking them, I would say asking general wellness questions instead of diving into an eating disorder inventory. That might be a little like, I'm not going to go back and see Catherine now because she gave me this eating disorder questionnaire on our second session. So yeah, I think that giving somebody that space to come to you with it. I mean, the exceptions would be if you're, somebody's, health is definitely a big concern. Sometimes we have to kind of dive in and get into it sooner, but to give them the space to have the use of the agency to do that and share it is a better way to go usually.
So, Tamie, I'm going to make an assumption that that is a cat that's playing right behind
Oh
your
yeah.
left shoulder.
Let me, I'm, hold on. I can unblur my screen, but she's my emotional support cat.
There you go. Okay. All right. I kept seeing this ghost-like figure moving, and I'm there like, that's either a cat, a dog, or we got a problem.
I can unblur. So when she's actually 2.5, but she was the runt. Her sister is twice her size.
Wow.
And so when I brought them home, I had to keep them separate from my older, larger cats. So they lived in this office for a couple months. And so this is her space. So when I'm on Zoom, she's on Zoom.
Makes sense. Okay. So you talked about, the therapeutic relationships, the relationship with the therapist, and maybe not going too fast too soon, and finding the safe space. But Tamie, you weren't always a therapist, and you probably had a time when you were seeing a therapist that it wasn't a good fit, wasn't a good relationship. How do you know when it's not a good fit, and how do you find a good fit?
That's a great question. How do you know when it's not a good fit? I always say it's, to give it at least 3 sessions with a therapist to see if it's a good fit. I would say, like, not very different than dating, right? Like, let's take some time to get to know each other. But I think really it's the fit on a personal level, as far as just feeling like a safety and a connection with them is almost as important, if not more important, than whatever therapeutic interventions they have. So I'd say, looking for somebody that might have, everyone's website has what their background is. So if you want a therapist who's LGBTQ or has ADHD or anything, that, finding that person, or chronic illness, finding that person that you might feel connected to before you even meet. And then also knowing that, like, they're working for you and you get to interview them. And so asking a lot of questions, and a therapist disclose as much or as little as they want to. And we're taught in school, right? We disclose when it's therapeutically appropriate, and all of those things. But I think too, you'll know that it's a good fit if you feel comfortable enough to start to let those walls down, just like you would with, friends or family that you feel comfortable with. And I wanted to, I didn't say what I wanted to go back to the disclosing eating disorders real quick because I wrote myself a note and then I didn't say it. So I can go back to that real quick. When Catherine was talking, I was thinking of my students in my class. A lot of times they'll come to class and not and they're, it's a 400, 500 level class. So they're, anywhere between like, 20 and on up. So this might be the first time they've heard, because everyone sees, anorexia, bulimia, binge eating disorder, and they in general know what they mean, but they might not know in more detail, or they don't know what ARFID is. And so they might have heard for the first time. And I get quite often actually like, I didn't realize I had this, or I didn't realize, I thought what I was doing was normal because this is what society is. This is what everyone in college is doing. We're all not eating all day and then eating, we're eating lunch so that we don't eat before we go out and drink. So just all these things that are normalized, are missed. And so a lot of times somebody coming into therapy may not even know that they have anything wrong with a disorder relationship with food because it's just normalized. So they might then come into therapy and hear for the first time that what they're doing isn't necessarily normal, or isn't, even if it's normalized in college or in society, it might not be good for you. So just kind of that, like, almost like an awakening sort of.
So let me free associate here just for a second, because something you said, I appreciate your answer, but something you said really kind of sparked something that many people do, and I know I do. You used an acronym, ARFID, okay?
Yes.
And so what happens in normal life, somebody gets sick. I have a family member that's very sick right now. And when something happens, or when a new condition, a new phase, she enters into a new phase, the doctor will, use an acronym. And immediately my family and I will start Googling, whatever that term is. And so that must happen in therapy as well, where someone probably assumes that they have an eating disorder or some other issue, or something that they want to address, but then they will immediately flip into certain types of therapy, like, do I need CBT, or do I need ACT, or do I need EMDR? Does anybody ever do that to either of you? And if so, how do you slow them down and say, I don't want to really give you a graduate education on what all these therapy modes are, but let's focus in on what we need to do. How do you stop the Dr. Google syndrome here?
I think I'll answer first. I think a lot of times clients might, that client that has an idea of what they want to do, either might be a therapist that's a client, which is common, right? Therapists go to therapy, or somebody that's been in and out of treatment for a number of years and they're more treatment savvy. And they want to tell you how to run their treatment. And so, I like to look at it really from a place of non-judgment, like, okay, tell me more about that. What worked? What didn't work? Why are you interested in EMDR now? And I think that, as you're saying, like CBT, ACT, EMDR, they're all helpful and useful tools, but, why don't you think CBT helped you before? Because maybe they didn't do a thought record, or they didn't know how to do it, or their therapist didn't review it with them. So I think try to really understand where they're coming from, in trying to dictate what treatment modality we should use. And then also as therapists, we have a lot of tools in our toolbox. And so we can always shift and pivot to different treatment modalities based on what they want to, like maybe they want to try EMDR. And so, being open to, I'm not an EMDR therapist, but I know a lot of great ones. So always like, I can refer you to someone that specializes in that if that's what you really want to try for your trauma.
I agree with that. I'm thinking of so many examples that are all over the place when I get myself organized. I think absolutely aligning and better understanding what the client maybe confused about or feel certain about, right? Oh, I'm understanding that you looked this up. Let's talk about that. Maybe provide some psychoeducation about why that approach makes sense for that person. And then if that approach or a new approach hasn't worked for them in the past, really working through what about it didn't work. Was it maybe not a good fit of a therapist? Was it maybe a similar approach, but not quite? Did you not have enough support? Were you only seeing your therapist once a month when it's an evidence-based treatment that needs to be approached twice a week? Kind of getting down to the nitty-gritty of, is this really an approach that you need, or is it a different type of support? And I think too, oftentimes people get overwhelmed. We want to empower our clients to educate themselves and maybe even sometimes seek a second opinion. But there's so much information out there about things that having a conversation and working through it sometimes can ground someone better in understanding what they need and make them more willing to try things, whether it's in the therapeutic relationship or maybe even treating in tandem with a second provider.
Well, all I can say is ChatGPT has helped many of us in our work, but it's got to make life a little bit more difficult if I'm using ChatGPT as my initial therapist or my system to diagnose my what I'm feeling. So
I haven't tried that, but I should try to do that and see what comes up. I have been slow to use ChatGPT for a lot of things. I use my AI and Grammarly to reword things all the time, but for ChatGPT, I haven't. But that's a really good point, right? I might try to do that and diagnose myself and treat myself, and it's not really effective. And I think the same thing happens for diagnosis also, right? So when we give somebody a diagnosis, especially if it's the first time, we're going to sit down and show them, this is what some people want to see, like what all the criteria are and like, where do I fit into that? What does that mean for me? Instead of me just going online and getting, and looking up and diagnosing myself. RFID, avoidant restrictive food intake disorder, is a really complicated diagnosis. I think one of the most complex because there's so many different variations. And so it's one where I can trick myself into thinking I don't have it. Or I can really miss and be like, oh, I don't have only 5 foods that I eat. I just have maybe the fear of choking. And so I don't fit into that. So it's really easy just to kind of take what you want from what you see online. To sit down with a provider to sit down and go line by line, explain to you, I think is really helpful. And diagnosis is helpful. I think a lot of people feel like it's stigmatizing, but for me, if I know what's wrong with me, same as medically, right? I know if I know what's wrong with me medically, I can get the right treatment. So, if I have anorexia and I don't really have ORFID, then our treatment plan is going to look a little different. So that the right diagnosis is really important.
interesting.
I think
Catherine,
there
go ahead.
certainly inherently a lot more benefits to seeking diagnosis with a living human being, because the first and foremost is that you're not alone. When you are being diagnosed by someone, whether it is your doctor or maybe an assessment psychologist for a mental health disorder, you have a relationship where they're assessing you, and they're almost like this investigator, right? They're trying to figure out what is going on. Why are you struggling? Why are you in this level of discomfort? And so you have that person, literal person with you the whole time saying, we're trying to figure this out so I can get you more support. ChatGPT, you're telling it, oh, I'm struggling here. And it's objective. It's not able to assess your level of pain. It's not able to, certainly, hopefully, not able to take your labs. It's not assessing your body language or your demeanor or your affect. And even if you typed in every single one of your symptoms by the book for a disorder, how does that help you with your lived experience of getting support, of having compassion, and having any type of instilled hope?
Catherine, you mentioned support, and moving off of therapists for a second. Everything that I read tells me that if I have a system of support, I'll live longer, right? I'll be happy. I'll be a happier person. And I was thinking about lack of support. I know in your book, Tamie, you mentioned at one time having to go to or being taken to the emergency room, and then whoever took you, I guess, left. which it was another moment in the book where I kind of stopped. It was like, there's got to be, how many more 2x4s can she like hit somebody with? This is like terrible. This is just like a horrendous situation. But people need support. So where should they be? And maybe they're not ready to see a therapist, or maybe they are already seeing a therapist, but they need additional support. What other things should they be looking at? Church groups or family or loved ones. Sometimes some of those people may understand or be able to help, sometimes not. But what's the support system that people should be looking to try and develop here?
Yeah, well, first of all, I'll say to that incident, well, because you read, I won't give away everything, but that was also a life-changing moment for me that led me in a different path, right? So I'm not, and so unfortunately, sometimes we need like things like that to happen to be like, oh, I don't need to be in this relationship. It's time to, if I didn't notice before, this is a reminder, like, get out of this, support can come from in a lot of different spaces, right? I mean, there's some really great, virtual support groups. So the Alliance, I'm not actively doing groups right now just because my life got crazy, but I love the Alliance, the National Alliance for Eating Disorders, because they have free virtual, they have some in person, but free clinician-led support groups. There's a number of others. I love support groups, in higher levels of care, like residential treatment, day treatment. We do group therapy all the time, so we should do that probably when we leave, right? So I think support groups are a great way because somebody might not have close friendships or may have pushed people away. And so a group is a great way to kind of dip your toe in it. Like maybe I'm going to show up, but I'm not going to talk. And then maybe Catherine says something in group that I relate to. So maybe I'll chat about it, or I'll raise my hand and say something. So I think support groups are a great way to do that. And then also, if you have, one trusted friend or a family member to be able to start to share that, because, we heal in relationships, we need people, we know that. So to be able to, if somebody comes into therapy, to encourage them, like, who is somebody in your life that you can identify?
Well,
Support.
even with that, I spoke to somebody who did in fact have an eating disorder, and their biggest fear was that their wife would find out. So obviously, it was well, I guess I shouldn't say obviously. It was a male, a guy, and he was afraid that his wife would find out that he had an eating disorder. So how do you ask for help? Because here's just an example of someone that was hiding it, which probably happens all the time with addictions.
Absolutely. And, I think certain groups are more stigmatized. I mean, I think there still is that, men don't have eating disorders, right? We've known this for many years that men do, and all genders get eating disorders. And I think, it still is a missed population. We still definitely had a number of males in our groups with the Alliance. And so I think, my hope is that he will eventually be in therapy and feel comfortable enough to share with his wife. But I think encouraging, I'll go back to groups, but also that, I know it's really uncomfortable and you might feel a little bit better if you can hear from another person. That's to me one of the greatest things about the group experience. It will trigger you for sure, into looking at your issues, but also just hearing from another person that's not a therapist necessarily, from another person that like has the same struggle as you, that knows what it's like to, still be ashamed and not want to tell anyone that you have an eating disorder, or just that, even we don't get into details of symptoms in group because that's a no-no in a group setting, but just to hear it from somebody else. So, and if somebody's not ready to do that, there are some really, social media is a tough one. We can dig into that later if you want, but there's some really positive, recovery focused social media accounts. So maybe you can take a look at some of those, just really kind of tiptoeing into it. And then also I always wonder, do you think this is something you can recover from? Because a lot of people don't think that they can. Like, this is just something that I have. Like, he might think he has this and he's always going to have this and he's never going to tell his wife because he doesn't want her to know, because maybe he thinks that she's going to leave him. So then we go to our CBT, right? Let's look at all the thoughts that come up when we think of, telling your spouse. So there's a lot of layers to it.
And I think that shame and that stigma, not only does it thrive in isolation, but it functions as keeping people really sick. And finding any type of support, I think, in and of itself is better than no support. Even if the goal isn't to disclose what your struggles are or go to therapy, having a friend, a loved one, someone you can relate to and talk about any number of things allows you to be able to better cope and then feel safe to maybe then get the support that you need.
So let's explore this just a little bit more. I mean, what are my expectations once I find my support system, I find a therapist, I find a doctor, whatever the case may be, I get to the point where I'm comfortable enough disclosing that I have an eating disorder. What are my expectations? Will I be fine in a couple of months? Will I not be fine in a couple of months? What happens here? Because, at least I live in a consumer society, right? I want something, I buy it, end of story, I got it. I feel instantly grateful. So when am I going to be fixed? When am I going to feel better?
Well, it depends on what the definition of feel better is. I'd say, initially you're gonna feel better just by starting the process, not necessarily actually. Sometimes starting the process is really difficult. That's why I always compare it to the physical, right? Like recovering from a surgery or an injury, like sometimes it's going to be painful. You're going to physical therapy. So, there's no timeline as far as when somebody's going to feel better, if that means fully recovering for them. The timeline, I'd say, I hate to throw out numbers, but the average used to be, we would say 5 to 7 years for full recovery. I don't know that I necessarily agree with that anymore. I'd say maybe that 5 year time frame could be when we get to the place where I don't have symptoms, I don't have thoughts about my body that are negative, I don't have any eating disordered thoughts. So to get to that place where it's something that you used to have, it could take that number of years. But really, if you start working with, your therapist, dietitian, like once you get a whole team on board, then it's going to take, I don't know if you have a number, Catherine, that is still going to take a good amount of time, because we're not looking only at what we're doing with food, what we're not doing with food, what we're doing with movement, but then we're also digging into what's the underlying issue. Is there trauma that we're going to work through? I always like to say, though, you can still work on your trauma after you've recovered from your eating disorder. So you can start it in the process, but you don't have to have all of your trauma fully resolved in order to recover. And as you've read from my words, I definitely had worked on my trauma long past my eating disorder being in my history, right? So I don't really have a number other than you're not going to feel fixed right away. It's a difficult process, but once you have a team that you trust in place, you'll feel a lot safer and more equipped to do the work. So I don't have an
Okay.
answer, unfortunately.
I agree. I agree. And I think it's relative to how the person is doing when they're come in, right? If they're not appropriate for this level of care and need a higher level of care, like an intensive outpatient or partial hospitalization or residential, then they need to go through that process of stepping down and graduating to outpatient. But if they're coming to outpatient therapy, maybe they're in remission, maybe they're fairly stable. I think we have to look at the medical component of, is this person nourished enough? Do they have enough social supports? Do they have a team? And if that's all in place, depending on the person, it could only be about 6 months. It could only be 4 weeks before they start to see some improvement. But I absolutely agree that it doesn't get worse before it gets better, but it gets harder because you're having to change the way that you're living your life to get better. We have to make changes internally, behaviorally, emotionally, in therapy to be able to see progress. And that sometimes can feel really challenging. And that's when we do see some regression, but that's part of the process since progress isn't linear.
Well, it's difficult. But I'll just use an example. If I'm having a difficult time, I have 2 drinks at night. Maybe I'll have a third. Maybe I'll have a fourth, or whatever the case may be. If I'm hungry, maybe I just found out about double stuffed Oreos. Maybe I'll have a double stuffed Oreo, or 5, as the case may be. What are you've both either had to deal or have helped people deal with figuring out how to cope with particular issues? What are healthy coping skills that people should be looking at or looking to try and develop?
So they're different for everyone. I will start by saying double stuffed Oreos are awesome, and there's nothing wrong with having them. If somebody says that that's right, I always like to say we don't want to pathologize anything. If somebody's having a third drink at night, like, is this a normal thing? So anyway, since you mentioned that, but I always say there's these crazy long lists. This is one thing that we can maybe find some help with Google. There's a really long list of coping skills because everyone has different things that are helpful for them. I will use myself as an example as I always do. I had a lunch meeting cancel yesterday, and I was like, I can fill this with a bunch of stuff, but I've had a lot of life stuff happen, so maybe I will. I went to Hobby Lobby, and I used to paint all the time, and I was like, I'm gonna buy some canvas and some paint. And I sat there and painted for 2 hours. And it was everything that I needed yesterday. Somebody might hate art and creative things, but like for me and for a lot of people, that creative outlet uses, the different parts of your brain. It's like a mindful distraction. So I like a mindful distraction. There's also nothing wrong with something that's mindless distraction, like watching a silly TV show. So I think it's coming up with starting with, what things are helpful for you in your day to day, and then trying out some different things. Like maybe somebody tries a coloring book and they're like, that was dumb, that didn't help me. Okay, fine, we won't do that again. So sometimes it's really a process of elimination. Um, I think that things that are grounding are really helpful, like grounding with your senses, or like it's like a basic coping skill that we use, like grounding with your 5 senses. I think it's helpful for most people. I can't say for everyone. And so practicing some of those things in the session and then sending somebody home with homework to do to try these 10 different things this week and see if some helped you with coping.
Okay.
I think for many people, having access to double stuffed Oreos at all times might actually be incredibly adaptive if they weren't permitted to have those growing up, truthfully.
Yeah.
And I kind of tongue in cheek, my kind of analogy for coping skills is I think of caffeine. You want long-term and short-term. So your long-term coping skills are like your slow brewed green tea, where you could have that every day. Probably wouldn't be have any issues. And these are things that you reap the benefits from over a long period of time. So positive relationships, healthy movement or exercise, nourishing yourself, staying hydrated, getting enough sleep, maybe going to therapy, having a medical provider, things that when you're taking care of yourself in the long term, you're benefiting from them in the long term. And then your short-term coping skills are 5-hour energy shot is something that maybe you need in that moment to distract or engage in. But if you rely on those every single day, you're probably not going to feel so great. This is something that you can do maybe if you're really stressed at a bus stop. You don't need a specific context. You can literally pull out that coping skill right there, no matter the context. And this is calling a friend, distracting yourself, right? Maybe you could doodle, eating a peppermint just to kind of distract yourself, have a sensory experience in the moment, drinking some cold water, doing a meditation, things that you have access to ground yourself that maybe don't take you out of that emotion fully, but allow you to get to the next long-term coping skill or get some more support.
So let me kind of summarize, at least from my perspective. I'd like to give each of you 30 seconds or so to summarize where you are, and then I'll close. But let me say, Tamie, I truly enjoyed your book. chronic illness and eating disorders.
Yeah.
I know you had the word count because it's like in your head. It was actually a very quick read. I mean, I do tend to read quickly anyway, but it was actually a very, very quick read. It was very emotional and very jarring at times, but very worthwhile relative to the topic and understanding how things have happened for you and for others, because you talk about other people's lived experiences in that, as well as things to do and sources, references, etc. So I really appreciated the book. I appreciate the time from both of you. You know, it helps you know, me learn more. Hopefully it helps our audience learn more and learn where to reach out for help, and that help is available. So I appreciate the time that you guys have spent. Catherine, anything that you would like to leave for our audience or tell our audience?
Oh my goodness. I have to say I loved your book, Tamie. I'm a very slow reader and I got through it very quickly and I reread some parts and saved a lot of the resources. And honestly, a lot of it was a reminder of resources that I have, a reminder that these are really valuable for clients. And I think if you are struggling with needing support or you have someone that you care about that needs support, being there for them, listening to them, showing up for them in that relationship, and acknowledging that everybody needs to take their own time to get support and be in recovery, and that being a stable support, whether you're a provider or a clinician or a family member, goes so much further than we really know.
Thank you both for your time. Thank you both for reading my book. It's you know, there's a part of it that's like terrifying to be like, here you go, here's all the things I said. So thank you for taking the time to read it. I think for me, I always like to bring up the hope and resilience piece of it, that you know, so many people do fully recover. It's not a life sentence if you're diagnosed with an eating disorder or substance use disorder, or you know, anything mental health related, for that, as far as that's concerned. So there's hope in recovery. You don't have to recover alone. And then the resilience, I would say the resilience for me is, you know, I don't have to wait till I'm not in pain to live my life fully. And so that if you are struggling with a chronic illness or chronic pain, just know that, you know, I always say, like, I see you, I hear you, I'm in it with you. And you don't have to wait till that feels better, whatever that is, in order to live your life, and that you're probably way more resilient than you realize. So hold on to that.
Now, your book, I believe the paperback version is like $33, something along those lines. Is that correct?
Amazon says $39.99, but
39.
I think when it comes out, I think there's like a discounted rate when it comes out. I'm getting mixed info, but I can send it to you. But yeah, the official release date is August 29th.
Okay.
But you can obviously pre-order it now beforehand. So
Great book. Well, our sponsor today is Equilibria Psychological and Consultation Services, whose mission is to help individuals achieve their personal potential and long-term growth by compassionately and respectfully helping clients live in balance. Visit equilibriapcs.com, equilibriapcs.com. Look for them on Facebook, Instagram, as well as LinkedIn. I should be on the same. Now for my disclaimer. I am not a medical professional and I am not providing medical advice. The opinion of our speakers are solely theirs alone. And this podcast is copyrighted and cannot be reproduced without the express written permission or written consent of EPCS Management, LLC. So thank you for joining us today.